Janine, we can't hear you. Sorry. Janine? Janine, I'm sorry, we can't hear you. Janine?
Now you will hear me. I'm sorry.
Excellent.
Okay, you've seen the program, so I don't have to repeat it, I think, and I would like to give the word to Sophia Jordao and afterwards to Nele, and I will be the last one to do my presentation, and you can ask your questions at the end.
Sorry. Okay, just a moment. Just a moment. Let me see if I did something with the... I'm sorry for the technical issues. Let me just fix it. Can you try now, please? It's not working. Is it working now?
I think it is now. Thank you. Can you hear me?
Yes.
Okay, then I'll just share my presentation. So my name is Sophia, and I will start with the background covering definition, nature, classification, prevention, and briefly the management of this condition. Thank you all for being present with us. So at its core, lymphedema is an expression of inadequate functioning within the lymphatic system. Some considered experts regard peripheral lymphedema not as a condition itself, but as an indicator of an underlying issue within the lymphatic system, a symptom, if you may. However, it is officially recognized as an illness by the International Classification of Diseases established by the World Health Organization. Lymphedema can either occur in isolation or be interconnected with various other local complications, and in severe cases may contribute to potentially life-threatening systemic syndromes. Lymphedema is a chronic medical condition that occurs when there's a blockage or damage to the lymphatic system, causing the accumulation of lymph fluid in certain parts of our body. And as there's currently no cure for lymphedema, managing this condition focuses on minimizing symptoms and improving the individual's quality of life. Individuals at risk or diagnosed with lymphedema are often encouraged to work closely with healthcare professionals specializing in lymphatic conditions to develop a personalized management plan tailored to their own needs. So lymph is a clear, colorless fluid that forms part of the body's lymphatic system. It circulates through the lymphatic vessels, carrying crucial components such as white blood cells, proteins, and cellular waste products. Lymph is generated from the fluid that leaks out of the blood vessels into the body tissues. This leaked fluid contains essential substances that need to be filtered and processed before being returned to the bloodstream. The lymphatic vessels collect this lymph fluid, filtering it through lymph nodes to remove waste, toxins, and pathogens. After processing, the cleaned lymph is then returned to the bloodstream. In the case of lymphedema, there's a disruption in the normal flow of lymph. This disruption can occur due to various reasons, such as damage from surgery, radiation therapy, trauma, infection, or congenital malformations in the lymphatic system. When the lymphatic vessels are damaged, blocked, or missing, the normal drainage and circulation of lymph are impaired. As a result, the affected area experiences buildup of fluid lymph causing swelling. And this swelling occurs because the lymph, unable to flow properly through the impaired vessels, accumulates in the tissues, leading to an increase in volume and pressure in the affected body part. Venous edema and lymphedema are both conditions that result in swelling, but they arise from different underlying causes related to the body's circulatory and lymphatic systems. Venous edema occurs when the veins have difficulty returning blood to the heart, leading to an increase in pressure within the veins. This increased pressure causes fluid to leak out from the blood vessels and into the surrounding tissues, resulting in swelling. Venous edema often affects the lower legs and ankles and is associated with symptoms like skin changes, ulcers, and pain. Lymphedema, on the other hand, is related to the lymphatic system. It occurs when there's a blockage, damaged, or developmental abnormality in the lymphatic vessels or nodes. This obstruction prevents the proper flow of lymph, leading to a buildup of lymphatic fluid in the affected area. Lymphedema can cause persistent swelling, a feeling of heaviness, limited mobility, and an increased risk of infections. Lymphedema can derive from different causes and be classified accordingly. So primary lymphedema is mainly due to inherent malformations or abnormalities in the development of the lymphatic system. These abnormalities might involve missing or insufficient lymphatic vessels or nodes, leading to impaired lymph drainage. Secondary lymphedema is caused by damage, trauma, or external factors that affect the normal functioning of the lymphatic system. This damage often occurs due to specific events or conditions. Despite the cause, the shared factor is the compromised capacity of the lymphatic system to effectively handle the macrovascular filtrate, including plasma proteins and cells that typically seep from the bloodstream into the interstitium. The difference between primary and secondary lymphedema lies in the underlying causes or triggers that lead to the development of the condition. Primary lymphedema is typically due to developmental abnormalities in the lymphatic system. These abnormalities might include missing or insufficient lymphatic vessels or nodes, leading to impaired lymph drainage. It is further categorized based on age of onset. Congenital, when present at birth or in early childhood. Early lymphedema, with onset during adolescence or young adulthood, usually before the age of 35. And late lymphedema, when it develops after the age of 35. Primary lymphedema is also very often related to genetic causes being sporadic, hereditary, or caused by specific syndromes. Secondary lymphedema develops as a result of damage, trauma, or an external factor that affects the lymphatic system. This damage can be due to benign or malignant causes, meaning conditions that disrupt or block the normal flow of lymph through the lymphatic vessels or nodes. Secondary lymphedema can occur at any age and usually appears after a triggering event. The management of lymphedema, like most, if not all, chronic diseases, starts with prevention. Many publications highlight risks for secondary lymphedema, often offering do's and don'ts. Unfortunately, many are based on weak evidence and lack of thorough investigation. While some advice, like avoiding excessive heat or unnecessary treatments for at-risk limbs, makes sense, other suggestions, like avoiding physical activity, aren't well supported. But let's focus now on what we know about preventing lymphedema. Factors like being overweight, extensive lymph node removal, invasive surgeries, and certain therapies seem to have a more significant impact on causing lymphedema. However, during surgery, there are techniques to reduce the impact of the lymphatic system by identifying and avoiding specific lymphatic vessels. Some promising methods, like prophylactic lymphatic venous shunts, show potential in lowering the risk of lymphedema after surgery, especially for high-risk patients. Also, ongoing studies are looking into various approaches such as exercise, weight loss, self-manual lymph drainage, and education to prevent secondary lymphedema. If lymphedema cannot be prevented, the next priority for successful outcomes is early detection. Prospective surveillance models offer early lymphedema detection, enabling timely and effective interventions. This model includes devices like bioimpedance spectroscopy, bioimpedance analysis, or tissue dielectric constants to detect early tissue fluid changes. Patients can also be regularly monitored at specific intervals, assessing lymph volume and function to detect subclinical onset of lymphedema. Identification at low diagnosis thresholds allows early conservative interventions, reducing the progression to chronic changes. Early identification and treatment of lymphedema enhance success and cost savings via conservative management programs. And how is lymphedema diagnosed? An accurate diagnosis seems to rely on imaging or genetic techniques. So imaging-wise, we have a lymphogeoscintigraphy, which is valuable in visualizing lymphatic abnormalities in structures, and also newer diagnostic tools such as magnetic resonance imaging, near-infrared fluorescent imaging, dual energy X-ray absorptiometry, and ultrasonography that are being increasingly utilized for lymphedema diagnosis and assessment. As for genetics, we have genetic testing, which is used to screen for specific gene mutations linked to lymphedema-related conditions, and also gene identification, as various genes are found linked to familiar syndromes and congenital and genetic disorders. The treatment for limb lymphedema primarily involves physical therapy. It is a chronic condition that requires lifelong care, much like other long-term health issues. Long-term care for chronic health conditions doesn't mean treatment is unsatisfactory, though it may not often offer an ideal solution. So patients need to think of it like managing diabetes, for example, where continuous care with insulin or specialized diets is essential to maintain balance. Patient cooperation is crucial for positive outcomes with chronic conditions. In chronic venous insufficiency, for example, poor adherence may cause skin changes and other issues. Similarly, uncontrolled lymphedema can lead to infections, severe skin changes, potential disability, and rarely more serious conditions. Tailoring treatments based on individual needs, considering factors like mobility and frailty, is key to providing optimal care. But what is nowadays believed to be the optimal management of lymphedema and the disparities in treatment access that derive from geographic and socioeconomic factors will be now addressed by Nell as we carry on with our presentation. So thank you very much for your attention.
Thank you, Sophia. I will also share my screen with you. And now I have to put it in presentation mode. I hope this works for you. You can see the slides and you hear me? Okay, perfect. Thank you, Sophia, for the nice introduction. I will go on with the presentation as you mentioned, and I have two things I really would like to discuss with you today, as we are all here, or mainly physiotherapists. I thought it was very interesting for you to tell something about the ISL consensus, which is a document that is international, that we are aware of and that we make every 2 years. It's a consensus about diagnosis, what already was discussed by Sophia, but also on the treatment of peripheral lymphedemas. And on the other hand, with our group, we are also doing a survey for different countries, different member organizations of the World Physiotherapy Association. And so I will guide you through these two topics. I will start first with the consensus document, which is from the International Society of Lymphology, and it was updated a few weeks or already 2 months ago in September in Italy, in Genova, because there was a Congress, the World Congress, already the 29th Lymphology World Congress. And so every 2 years they organize it with the committee, and there we work on the consensus document. And so I think it's, as international document, it's very useful for us as physiotherapists to work with this. And so I made some conclusions, which are the most relevant for us as physical therapists, but they are always published in the journal that you can see in the right upper corner of the slide, called Lymphology. So it's not published yet. They are still writing it. And of course, it takes some time to have before we can have the publication. But so the whole text, you will be able to find it in this journal. So what is important for us as physical therapists, and Sophia already mentioned it a little bit, there are 4 main pillars that we as physical therapists can use to treat and also, as was mentioned before, prevent lymphedema. And the 4 pillars are manual lymphatic drainage, compression therapy, skin and wound care, and exercise and movement. And exercise and movement will be discussed by Janine later in this presentation. So I will focus on the main parts, the main 3 parts. And these 4 together, we call them complex physical or complex decongestive therapy. And as you can see in the slide, there are also 2 phases. And the first phase is the decongestive phase or decongestion. And the second phase is the maintenance and optimization phase. So I think it's very important that for our patients, if we treat them, that we can also recognize those 2 phases. It's very difficult to have a one-size-fits-all program. That's also what was already mentioned by Sophia. Everybody needs a tailored program, but these 4 pillars are very important in the treatment and prevention. As physical therapists, and when we look at it around the globe, I think manual lymphatic drainage is the pillar that is mostly executed by physical therapists or physiotherapists worldwide. The compression therapy, it's also mostly physiotherapists, but also nurses or other health workers. And skin and wound care, I think it's something that is in the first place self-management, which you can also see in the picture at the right side of the slide. But it's also something that we can take care of and that we need to look at when we are treating patients with lymphedema. So we can also refer them, for example. And skin care, it's not only wound care, it's also like hydrating the skin, etc. So I really want to focus on manual lymphatic drainage because that's the thing that we as physiotherapists are mainly responsible in this treatment, and that in most countries is not executed by other healthcare workers. And then I want to take you to explain this, the mechanisms of manual lymphatic drainage. I want to take you to the very basics. And it was already presented by Sophia, but when we zoom into the lymph capillaries, so the smallest lymphatic vessels that we have in our body, you can see that the wall, it consists of different endothelial cells that are flap-like based upon each other. And on these endothelial cells, you can see the anchor filaments. And the anchor filaments are attached to the walls of the interstitium, but also to the skin. And what you can see is when there is, in the microvascularization, there is fluid coming into the interstitial space, the interstitial pressure will increase. That's what you can see at the right side. So in picture B, where the interstitial pressure is increasing, and you see when the when the pressure is increasing, that the anchoring filaments are stretched and that they are tearing those endothelial cells up so that you can have an influx of, for example, proteins and fluid. And when you have this influx, they are sucked into the lymphatic capillaries and then they are transported. That's what you can see in picture C. They are transported to the pre-collectors, to the collectors, and so on, to go finally to the lymph nodes, of course, like Sophia mentioned, and then in the end it comes into the bloodstream. But what we can do as physiotherapists within this mechanism is when we move the skin and we have low pressure, like it's not really a massage, but it's really a skin stretch and a movement that we do that is called manual lymphatic drainage, then we can open these valves so that the proteins of the interstitial space can flow into the lymphatic system, and then it can be evacuated. And so it's very important that the proteins, which are big micromolecules that are hydrophilic, that they are removed from the interstitial space, because when they stay behind, they will attract more water, and so the lymphedema will get worse. So we need to evacuate, especially the toxins and the proteins from this interstitial space. There has been several publications and evidence about manual lymphatic drainage, and this is already a publication from 2010, so 2010, but there has been evidence from back in the 80s up until now, but I chose this one because it's a very nice summary of the evidence. And so there is fundamental as well as clinical studies that indicate that with manual lymphatic drainage, we can increase the filling and the emptying of the collectors. So we can, as I was just explaining the mechanism, we can fill these capillaries, but also empty the oedematous tissue. So if there is a tissue that has fluid, we can empty them as well. We can also, with manual lymphatic drainage, enhance or increase the contractions of the lymphangions. So you know that in the lymph collectors, you have valves, and in between those valves, this is called lymphangion, and it's the functional unit of the lymph vessel. And so if we can have a contraction, of course, it is induced by the autonomic nervous system, by the sympathetic innervation. You have these contractions, and we can transport the fluid and the proteins within the lymphatic system. So that's also something that due to our manual lymphatic drainage, that we can improve those contractions. And of course, contractions means that there is better transport. Also, the suction effect that I was explaining in the interstitial space is increasing due to the manual lymphatic drainage. The tissue pressure and the volume of the edematous lymph can decrease, so there is a reduction. And the accessory routes can be stimulated. So we have sometimes they are called sleeping lymphatic vessels within our body, like, for example, transpectoral or transdorsal vessels that are sleeping. So we do not use them in a healthy manner, but we can stimulate them whenever necessary. For example, when they remove the axillary lymph nodes after surgery, after breast cancer surgery, and the fluid cannot be drained through this site anymore, we can try to stimulate those transpectoral lymph vessels and try to remove it through the other side, so the heterolateral side. That's also something that we need manual lymphatic drainage for. So the role of the physiotherapist is very important in this phase. Then there is also evidence about the calming effect of manual lymphatic drainage through the autonomic nervous system. So as I was explaining, the innervation of lymph vessels to make them do those contractions, it is through the autonomic nervous system. And if we do the manual lymphatic drainage, there is a calming effect. And so we can have this effect as well on the lymphatic system. There is also a most recent publication by Barbieux-Romain and his co-authors. And this also gives the latest evidence on what the effect of manual lymphatic drainage can mean for our patients with lymphedema. I really zoomed in and I highlighted this part of the CPT or the CDT because there have been a lot of controversies around the globe and in different countries, because there, of course, it's very time consuming, the manual lymphatic drainage. And so for the healthcare system, sometimes it's a big burden, but we really need to be able to do this treatment for our patients due to all these positive effects, although it is a time consuming and it is a burden for healthcare cost, because we know there is this evidence, and so we need to keep on doing this for our patients. And then there is an overview of the worldwide lymphedema care by physiotherapists based on this survey. This is only the preliminary results. So we have a survey, and in the first phase during last summer, we distributed this survey to different member organizations, and we have these first results in, and I analyzed them, but it's only a global view on what we have until now. In the second phase, we will have a second round of distributing the survey, and so we will have more results to discuss with you. Shortly, the methodology on what we did to make or to build this survey, it was 2 online meetings to discuss what we really wanted to know with this survey, because of course, as was discussed in the first part of this presentation, there is this CPT or CDT that is evidence-based to treat our patients. But of course, we all know around the globe, there are not the same resources, there is not the same education for all physiotherapists, and therefore we wanted to know what the current situation or the current state is on lymphedema care around the world. And so we built this content of this survey before we distributed the questionnaire. And so therefore we did 2 online meetings. We did 1 review round, and there were only minor revisions for clarifications that we had to modify. And then we did 2 test rounds, because first we did it in a document. We described all the questions, but then we digitalized it into the survey, and then we did 2 test rounds with this digital form. And then there was 1 minor revision. So it's the speakers of today, together with Caroline Snyder, who is also from the Netherlands. And then we divided the survey into 3 main parts. First part was the general information. The second part was the clinical services for lymphedema patients. And the third part was the physical therapy education and skills. And so in the end, we had 28 questions. Most of them were multiple choice questions, but there were also open box questions. This is the QR code that you can use to enter the questionnaire or the survey. And in the next presentation, I will put all the countries that we have gathered in the chat box. And so if you are present here today and you notice that your country is not yet involved in this survey, we kindly invite you to complete this survey so that we can have the information from your country on lymphedema care or lymphedema services. What we did, so the World Physiotherapy has different members or member organizations, and they have 127. We all send them an email, and after a few weeks, we send them a reminder. And that's what we did together with the distribution during the months of July and August this summer. And this is what I was explaining to you. This is the first round. In the general information, we gathered 48 answers, from 48 different countries. It were more answers, but that's something I will discuss in the discussion of this presentation. But so we had 48 different countries. This is a response rate of 37.8%, which for a first phase, I think it's very well. But of course, this means that there are 62 non-responders in the first round, and therefore we will organize a second round. The clinical services for lymphedema patients. So in the results, what we could see was that the provision of physiotherapy services to people with lymphedema was 95.4%. And this is very high. And of course, we are very happy with this. But this means that there are still 4 countries out of the ones that we have gathered that do not provide any physiotherapy service to their patients. It's almost divided 50-50, self-referral of patients to go to the physiotherapist or not. And the main barriers to establish these services for physiotherapists was the lack of knowledge and understanding of the role of physiotherapy within lymphedema management, the lack of acknowledgement of the diagnosis by the medical staff, or the lack of treatment funding and resources. So those were the 3 main barriers that we detected why it was difficult to install these physiotherapy services for our patients. What we also analyzed from the results was that the majority of physiotherapy services are provided as public and private services, but this is only 57%, which means that some of them are just for charity or just for research. So it's not embedded in the healthcare system in every country. Most commonly, the sessions are provided individually to the patients when you have the physiotherapy one-on-one with the patient and in outpatient settings. So not in the hospital, but outpatient settings. The services are mainly available at all time points, which means from prevention up until palliative or end-of-life care. But most commonly, in over 75%, it was in the early stage. So for example, right after cancer treatment, or in the long term. And the long term was defined as over 1 year post-diagnosis. So the most treatments were given right after the diagnosis, or in the preventive phase, or in the long run. Assessments by physical therapists were not available in almost 30% of the countries, which is a lot, I think, that physiotherapists do not do any measurements with the patients. But for those who did measurements, questionnaires and volumetrics or perimetrics were the most commonly used, but that's, as you can see, almost only 50%. When we ask in the survey, do you use the CPT or the CDT, and do the patients have access? For those who had the access for the patients, 88%, 88.5% had the manual lymphatic drainage, as well as the compression therapy. 80.5% had exercise, and 66.7% had skin and wound care for their patients. So we see that it is more or less divided as in CPT, but some of the countries only give 1 or 2 of the pillars and not all 4 of them. But manual lymphatic drainage and compression therapy are the most commonly used in these services. And then we have the third and last part of the survey on education and skills. And there we saw that in almost 50%, lymphology was not a part of physical therapy education. So in almost 50% of the countries worldwide, in the physiotherapy education, which is very variable and heterogeneous, sometimes it's 3 years, sometimes 4 years or 5 years of education, lymphology is not a main part of this education. So when they want to specialize in this field, they need to do postgraduate courses or lifelong learning programs, or they need to study other directions to get this specialty. Also, about 50% does not have a special interest group in lymphedema. So when in a country they have a physiotherapy group in the member organization, about 50% does not have a special group that is focusing on lymphedema. And 64% does not have a register or requirements, criteria for recognized lymphedema or lymphology specialists. So this is the majority that does not really define what a physiotherapy with this specialty needs or requires. And also they do not have a register on specialized therapists. So as a discussion and conclusion from this survey, it's only preliminary results, so we still need to do a lot more rounds to, first of all, of course, to have an increase of the response rate, to have more results. And what we also saw that when we divided the survey to the different countries, we had 48 countries, but we had 87 responses. So in the big countries, we saw that in different regions, it was completely different. So it doesn't mean if you have one member organization that all the regulations and all the accessibility, for example, for lymphedema care is the same. So it will take us a lot more time to make sub-analysis. And in the big countries with different regions, we will be able to do to recognize these regional differences and to make this sub-analysis. What we wanted to do with this survey is especially to have awareness, equity, and inclusivity, because we think it's very important that the patients can have access and the optimal care for their lymphedema. What we also want to do with our group based on these results of this survey is to have recommendations or create like a consensus on education, because we see this is really a lack that is existing now for physiotherapy in lymphology. And we also encourage to have more North-South collaborations and to share knowledge and know-how on what we are doing for our patients. So that's it for my part. The questions, as was mentioned, will be at the end. But for now, I close my presentation and I will give the floor to Janine. Thank you very much.
Yes, now I can speak. Thank you, Nele, for your presentation, and Sophia, of course, as well. And now
We can't hear you, Janine, for some reason. I'm sorry.
my mic is working.
Working.
Oh, fine.
No. Again, we have a problem. I don't know why you're muted for some reason.
So when I'm sharing, I'm muted.
I don't know why it's happening.
Yeah, that I don't know as well.
Let's see.
Yeah, it's true. The moment that you share your screen, then the mic is muted.
I will try again. Maybe it's working now.
I don't know why. Let me try to do this. Maybe I'll try to make you a host for a second and see if that helps, okay? Let's see now if that solves the problem. I'm sorry. Just a second, let me check again.
Yes, I'm host now. Let me try again.
No, it's not. Don't know what's going on because I didn't change anything in the settings. Oh, Nelly, do you have the presentation?
Janine, did you send the presentation to me? Otherwise, I can try to share it.
I'll send it, and then we try it that way.
Yes. Technology.
Yes, sometimes it's difficult. It's coming. And I can start already. The goals of the exercises can be stimulating the lymph flow, and on the other hand, exercise can be provided for patients at risk for lymphedema, or exercises also can be given for patients with lymphedema. It was already the next slide, Nele.
Yeah, but I don't, maybe it's too big, the load of the document to send it by email, because I didn't get it in yet. I didn't receive it yet. Was it sent from your part?
It was sent, yes. It's rather big, I think.
Yes, now I have it.
Okay.
Oops. And I will share it. Is this working for you?
Yes.
Okay, perfect.
So you can scroll down.
Yes, I go to the first
Next one. Yes,
symptoms.
here.
Yes.
Before starting the exercises, it's important to ask about the symptoms of the patients. You have to ask about lymphedema, you have to ask about pain, about discomfort, because that has influence on the activity level of the patients. Furthermore, in making the exercise program, it's important to know what activities are compromised, so you can design a personal treatment. What I mentioned in my lifelong career is that beliefs on exercise are very important, because it's still said that exercise has influence on lymphedema in a bad way. And we already know for a long time that that isn't true. But when patients believe that, we have to explain very well, and patients have to feel comfort to exercise. For me, another important thing to keep in mind during training is how we can help to make a patient return to work, because that's important for the well-being of the patient. When we make our exercise program or our treatment program in general, in the Netherlands, we use shared decision making. And I think that's very important, because when you do it that way, the patient understands better what decisions are made and how it can be made. And there are different ways you can, different things you can use to make shared decision making. You can ask the patient-specific complaints. Other countries use the COPM or the patient-specific functional skill. When you exercise to stimulate lymph flow, there are different possibilities. You can use breathing exercises, especially deep breathing, abdominal breathing. You can use muscular contractions in the affected lymph area, articular movement, as Sophia said already as well. Arterial pulsation is helping to stimulate the lymph flow as well. And resorption by heart pumping, there's not many evidence about that, but I think it's of importance too, because the venous flow will increase by exercising. The breathing exercises, the most important is abdominal breathing. And we know from venous diseases that by abdominal breaths, the venous flow goes 20 times faster than without abdominal breathing. And from a study of Mosley and Piller, we know that Tai Chi is helping to increase the lymph flow as well by 4 times. And that's normally given in combination with relaxation, and you can use Qigong as well. And a very beautiful exercise of Neil Piller, he taught in our country for a very long time ago, is a Tai Chi exercise. You start with your fingers to the breast, open your arms, inhale, keep 1 second inhaled, and breath out, and come back. And it's very easy. The patient can do it sometimes, and yeah, that's for me a very easy exercise to give the patients to do at home. Muscle contractions, the most important effect of muscle contractions is the pumping effect. You have to start distal. So, for example, when you start. When there's edema in the arm and in the head, you start with making a fist, then you bow your elbow, you stretch your arm up, you extend your fingers, you make a fist again, you flex your elbow again, you extend your elbow, and you do that sometimes 5 times more or less. And yeah, in patients at risk for lymphedema, the most important is a healthy lifestyle, and that part is diet. Sophia already mentioned that a high BMI is a risk for lymphedema, and movement is important. And yeah, you can give exercise interventions as well, based on personal preferences and to train self-management. For a healthy lifestyle, the patient has to move at least 5 days a week for 30 minutes, or twice a week, combined with twice a week strength training, and patients aged over 50 years balance training. And that's the general health style intervention. And in exercises, yeah, we give it for patients with risk profile based on the medical treatment and on personal exercise behavior. So when the medical treatment, the lymph nodes are involved, an exercise intervention may be helpful. And persons that are moving yeah, too less, it's useful to give an intervention as well. And before starting the intervention, clinical reasoning is the most important part, but as it is always in physical therapy. So you ask for problematic activities, you do glycometrics, you make the goals, you look at disease, the preferences of the patients, the coping style, the illness beliefs, and that's the way you make the program. Oh, you make skip this. I'm sorry. Oh no! Oh no. The components of the treatment plan go on. Are cardiopulmonary treatment and strength training, but always on personal goals, on preferences, on risk stratifications. We discuss the treatment options, but also discuss the role of the physical therapist and the patient. So expectations of both sides are clear. This is what I do as a physical therapist, and for you as a patient, I expect you to do the other things, and you make your treatment plan smart. Making the program, we use the FIT-VP principles as is described in the ACSM. So the frequency, intensity, the time, the type of exercise, and volume and progression. Treatment, we try to do it in 2 to 3 months, and the exercise intensity and duration will gradually increase. In patients with lymphedema, I normally start with moderate intensity. And when you treat with moderate intensity, it's important to do it 5 times or more a week. If possible, you can use vigorous intensity for 3 times a week, or do a combination. And the time of treatment for moderate intensity for cardiopulmonary capacity is 30 minutes a day, for vigorous 20 minutes a day. And training muscle strength preferential, you do at least 2 bouts for every training. You give aerobic training, endurance, muscle strengthening, and for patients that have very much problems, you can start with graded activity. And I always combine with balance training by risk of fall, bone strengthening exercises for patients using hormonal therapy, and stretching exercises. I think we can continue with the next one. During the training, you can use the Borg score. I always use at least somewhat hard intensity, so the patient has to feel that. And you can use the steep ramp test or the shuttle walk when you do high intensity training, or the 6 minutes walk test or 10 meters walk test as a starting point when you use lower intensity. And for muscle strength, you can use the handheld dynamometer, or get an impression by the timed up and go test, or the 30-second stand test. And for the muscle training, the modified 1RM, the microfat or fitness equipment. We already talked about that. Sorry, I think because of time, I will skip the graded activity, but it's and what I will discuss now a little bit is the functional training. What I always try, besides the endurance training, and because besides the muscle strengthening, is making the training functional. So you really train the limitations in activities. You can start with simple tasks or cut tasks in simple parts. And especially for patients returning to work, it's working very good. But also in sports, for example, or for children with lymphedema. And during the training, you make the task more difficult in performance, in weight, in speed, and in duration. And you are going to combine tasks. It's fun for the patients and fun for the physical therapist, I think. You link also you link the functional training to activities and goals, to what is important for the patients. And yeah, for me, the most enjoyable thing is that you can play with your exercises. You can alternate, and yeah, you can stimulate the training at home by the functional training as well. So keep in mind that appropriate warming up and cooling down procedures are important. Education in warning system, signs and symptoms is important during exercise. Encourage sedentary individuals to regular walking, and counsel physical inactive individuals to start with vigorous intensity physical activity. Thank you all. Time for questions.
Yes, thank you very much, Janine. I will stop sharing the screen so that we can have a better look at each
See
other.
more people.
Yes. So if somebody wants to come in with a question, you can just open your microphone, unmute yourself, or put it in the chat box, or raise your hand. I see that there is a hand raised by Davidson John. Is this to ask a question?
Yes, to ask a question.
Yes, please go ahead.
Oh, thank you, Jenna, for and the co-presenter for this wonderful presentation on the role of physical therapy on lymphedema management. It's good. It's good. And the first presenter, though I didn't follow from the beginning, you know, I heard when he was she was talking about the challenges, you know, that some countries don't have a physical therapy role in management of lymphedema. Is true. I just want to share my experience. Then I'll ask a question or more of comment, because I practice in Nigeria.
Okay.
And I'm also the chair of the Hospice and Palliative Care of the IPT-HOPE. So, you know, developing countries, they have peculiarities. You know, most of these challenges are more in the developing countries, you know, because of lack of awareness by the population, the patient themselves, lack of awareness by the physiotherapists themselves about the role of physiotherapy in lymphedema care, or even in oncology and hospice and palliative care. The awareness is still low in many of the developing countries. Then secondly, because of the awareness, the curriculum, the undergraduate or entry-level curriculum, some of them don't have this oncology palliative care, you know, embedded in the curriculum. So that affects. But in some countries, they have started introducing it, like in Nigeria, we introduced it in the curriculum. But there is also another level of problem, challenge that we are facing. You know, in the specialist trainings, you know, they say they have orthopedic, cardiopulmonary, pediatrics, women health. Then the oncology itself and palliative care, where the specialized care for lymphedema would have been embedded, is not yet recognized as a specialty area. But yet we have each specialty organization, like Nigeria Society of Physiotherapy or HIV, Oncology and Palliative Care Physiotherapists. But then the young stars, you know, what I'm driving at is that the workforce, what affects the workforce in developing country, because the young stars that are fresh physiotherapy, the young ones, they always want a defined career pathway that is secure without much uncertainty. And when they see that this area has not really been recognized as a full specialty area where you can endeavor and practice fully, instead of being an interest area, they tend to shy away from even, you know, specializing in that area, because they feel their future is not guaranteed. So for the developing country, it becomes very important that we do fast and recognize oncology and palliative care physiotherapy as a full specialty area with specialized training post-graduation, in addition to adding this aspect of physiotherapy science in our curriculum as an entry-level curriculum and postgraduate curriculum. So I'm speaking it because I know some people from developing country would be listening. So it's a task that we have to go back to our various countries and make a case for it with our regulatory bodies and our professional association. Yes, our professional association, we have specialty groups, but then to recognize it as a specialized area where you can, do specialty training and become an oncology and palliative care physiotherapy. That is what is lacking. So it's an assignment for us to do. And I just want to share, I agree with the first presenter that it is real. That is why in some countries, and I presume in developing countries, you see that the role of physiotherapists in lymphedema care is reduced. It's not as much as in developed country. If you take out, you will see these kind of things. And these are few of the challenges that we have. And another challenge that we have, which we are trying to tackle in Nigeria, is health insurance. In a lot of the developing countries, we have low health insurance coverage. So the issue of paying out of pocket from this already impoverished set of people, with this terminal illnesses, like cancer that we predispose to lymphedema, is an issue. So some of them may not have the money to always come for physiotherapy to take care of the exercises and the lymphedema, because already they are paying heavily for chemotherapy, radiotherapy, and all other cancer care, which seems to be immediate, to save life. So after that, they are impoverished the more. So sometimes for them, coming for physiotherapy regimen becomes difficult. So we are now making case for more coverage of this aspect of physiotherapy in national health insurance. So other developing countries should also look toward that direction to lobby, advocate, and make a case with policy makers. So have this aspect of physiotherapy care covered by health insurance, so that even if we have majority of this kind of people living in the remote areas, because of course, we have inadequate number of physiotherapists in developing countries. So sometimes if you come to countries, you see them clustered in tertiary health institutions in the urban areas. The primary health care centers, you don't have them. So even at the primary health care level, this patient this group of people find it difficult to access it unless they come to the urban areas, which of course they're already impoverished. There are a lot of challenges, bad roads, and all other things. So if health insurance covers them, they will only be battling with their transportation costs only, not the treatment costs. Then we're also making a case to include physiotherapy in primary healthcare. So other developing countries, these are the challenges, because that's the paper we just finished submitting in Frontiers in Rehabilitation Science about ensuring the quality of care in palliative care physiotherapy. So we made literature review. We found out these challenges that I am mentioning, and they are real because they're peculiar even in Nigeria and some other developing countries. So that is part of my comment. So the second one is that in the second presenter, when I saw the management of lymphedema by physiotherapy, what we can do, I was also looking out to see a kind of complete decongestive therapy. I don't know, because that is what I use in my center in Nigeria when I do manual lymph drainage, compressive bandaging. Then the exercises, of course, the exercise is very, very key, because these people, they come down with a lot of disability of shoulder, hand, and arm issue. Disability of the shoulder, hand, and arm. So when you check them with that check the shape, you see that in my center I was having about 70% prevalence of disability. Some of them are teachers. They cannot go to work because maybe it happened on their dominant hand. They used to write. Secretaries in the office. Artisan business women that use their hand to sell. In the market. So sometimes they're out of job. So we do it aggressive. It's aggressive intervention, because it put them out of job. And sometimes when they lose their job, if it's not those that are self-employed, the rate of them securing a new job is 2 times more than people that hadn't cancer or such things. Literature has it. So I think if that complete decongestive therapy, I think it works. It works for me, and it works a lot. I use it a lot. I use it a lot.
Thank you, John.
That is just few of my comments.
Yes, thank you, John, for sharing this. And I completely agree with you. That's also why we mentioned we need those North-South collaborations. And please, I see that Nigeria didn't complete the survey yet. So it would be very helpful if you could take the QR code from the chat box and that you complete the survey. It will help us in trying to find solutions and make consensus for lobby work and to help each other out and to share the knowledge. Thank you so much for sharing this from the Nigerian part of you. And I saw in the meanwhile that there was a question coming in for Janine from
I saw it, yes.
Emma.
Yeah.
Emma,
yeah, bone exercises for bone density. The most easy is walking, but you have to do it at a speed of at least 6 kilometers an hour. So that you can use. And what I use as well is staying on your toes and get back to the ground with a little bit of force. Or when patients are accustomed, you even can jump. So that are the most easy exercises to do, and it's safe to do it in patients at risk for less bone density or even with bone loss. But all you do it in stand right up. That's important. So you have no torsion forces during your exercises.
okay, thank you very much. Another question that came up from, I need to check the chat box. Oh no, I think the chat box is okay for now.
Yeah.
Are there any other questions? I see someone has a problem with taking the QR code. So if you use the camera of your smartphone and you scan the code, it will take you to the website where you can complete the digital survey. And if there might be a problem, I can also send you the direct link. I will put my email address in the chat box again, and then you can just send me an email and I can send you the link for the website to complete the survey.
Okay, I think it's better. I will have to mail you so that I will give to Nigerian population and some West African countries.
Okay,
so
thank you very much. I can see another question from Kaisa. Where can I find the latest research about lymph node transplant? There was a lot of sessions on lymphatic surgery at the ISL Congress. And so I don't know if you saw it in my presentation, but I will give you the link to the website from the conference, and there you can see all the names, the institutions from the presenters, and that can take you to the latest research from their publications, for example. But the link, I will copy it here, and I will also put it in the chat box so that maybe you can reach out to the presenters, or you can look in literature for their publications. So it's www.isl2023lymphology.com. Does that
normally
work?
on PubMed you can find a lot of research as well. When you ask for a lymph node transplant, you will find a lot.
Yes, that's it. PubMed. If you go to the conference page, and then you take those names and keywords into PubMed, you will head for the right direction. Can we have any other questions through the chat box or through the microphone? We will be happy to answer. Otherwise, we need to keep track of time. We are running a little late because we started a little late and had some technical issues. But I think if there aren't any more questions, I would like to thank everyone for being present. Also my co-presenters for making these presentations, and Helena from the organization to help us out with the Zoom and all the technical aspects. Thank you very much. Does anyone like to add something?
Just to thank all of you and congratulate you both for your presentations that you came after me. So it's
Thank
very
you,
nice to
Sophia.
hear from you. Thank you so much for the opportunity, and thank you, Helene, for your efforts,
Yes.
taking into consideration all the background you're coming from. So thank you. We appreciate it very much.
Yes. Okay.
Thank you
Thank you,
for
everyone. Enjoy the rest
inviting
of the
me.
day.
Thank you so much. It was
And we
really
hope-
useful.
Thank you
Thank
very
you
much.
all.
And we hope to see you in the next occasions. And you can follow us through the website. Thank you, everyone. Hope
Many
to see
thanks.
you next time. Bye-bye.
Okay, thank you. Bye. Thanks.
Thank you very much.
Thank you.
Thank you.
Is it going to close by itself?
When I
No,
close
Helene
or
has
actually
to close, but
Jen-
I was waiting for everyone getting out.
Yeah, me
Yes.
too. Okay, perfect. Because I also need to leave. I need to be somewhere. Bye, everyone. Thank you.
Bye-bye.
Bye,
Bye,
everybody.
thank you,
Bye.
Helene.
Thank you.
You
Have a
too.
good afternoon.
Stay
Bye-bye.
safe.
Bye.
Stay safe with the
Thank you.
storm, Sophia.
Yeah, thank you. You too.
Bye-bye.
Bye-bye.
Bye. Thank you.
Bye.
Bye-bye.